Okay, so this is going to be considered part 2 of that neuro diagnostic test. So we were going over the angiogram or the cerebral angiography and the pre-procedure. So the patient should be NPO 6 to 10 hours before, or they may be on clear liquids. They do need to sign an informed consent for this procedure. We should remove all jewelry, dentures, hearing aids, etc. Sometimes sedatives may be used so that the patient can lie still. We do want to assess for any allergies to iodine or seafood, and if the patient is on any anticoagulant medications, because this could increase their potential for bleeding. This can take approximately 2 to 3 hours to do the procedure. If they are pregnant, it is contraindicated because the dye that's used can actually harm the fetus. And we do also want to make sure we have baseline vital signs, pulses, and neuro checks before the procedure. Okay, so during the procedure, angiogram, typically the femoral artery is what is used to inject the dye. So that's usually the side of entry for the catheter, and then the films are taken from that point. So a lot of times the patient may experience a hot flush feeling after that dye is injected, or they can also experience a metallic taste in the mouth. And they do often use that local anesthetic at the puncture site in order to kind of help numb that area. Okay, so post-procedure, you want to be sure to monitor vital signs, distal pulses, especially those pedal pulses, neurostatus. Typically, neurostatus is monitored every 15 minutes for the first hour, then every 30 minutes for the second hour, and then every hour for the next 4 hours. So we do this because of the possible risk for bleeding, and then also they could be at risk for stroke or also increased intracranial pressure. So I want to watch those neurostatus over the course of several hours. I also want to be sure to check that puncture site for any bleeding, for any hematomas, any redness or swelling. Once that catheter is withdrawn, we do need to apply pressure for at least 15 minutes. And then if bleeding does occur after that, then apply more pressure. But we do have to make sure to monitor that site, for several hours after the procedure. Again, typically that femoral artery is the one that's normally used. Sometimes the carotid may be used. If so, we need to be sure to assess for difficulty breathing or swallowing or an increased girth of the neck, just in case there were any type of bleeding or anything going on in that area. Post-procedure, we do want to increase fluids to try to help and kind of get that dye through the system. And then we usually keep them flat for at least 6 to 8 hours and on bed rest for a while. So flat 6 to 8 hours at least. All right, the next procedure is a carotid duplex. The carotid duplex, carotid ultrasound, sometimes you hear that called, uses ultrasound and Doppler in order to evaluate for carotid artery disease. There's usually no specific prep for this, but typically if the patient has had a TIA or is at risk for TIAs, they'll do this carotid duplex in order to look at those carotid arteries. You can see that the carotid ultrasound on the top left. And the EMG stands for an electromyogram, and this is on the bottom left, and this is going to be used to detect lower motor neuron disease, for example, myasthenia gravis. And it basically measures the contraction of those muscles in response to an electrical stimulation. So probably you all studied about this with musculoskeletal, so you can maybe look back and review that from there. But typically it's done for muscular diseases, but if a patient has like lower motor neuron disease, it may be done for that. Usually takes 45 minutes or so to complete that. And the last test I want to talk about is not in your outline. It is in your textbook, and just added this on there. It is the MRA, which is the magnetic resonance angiography, which is similar to the MRI, but it's an angiography, which means that it's going to visualize more of the specific blood flow in order to evaluate the extracranial and intracranial blood vessels. So it's looking more at the blood vessels. So sometimes strokes or occlusions may not show up on an MRI, but if you do that MRA, which is shown on your bottom right of the screen there, you can see those areas that are lit up. So it's looking more closely at the arterial, the arteries and those blood vessels. So it looks for those occlusions in those arteries. And you can read more about this on page 1875. Again, it's going to be similar to the MRI as far as prep and things like that go, but just know that it is different from the MRI. And the last thing here just lists some common nursing diagnoses that may go along with the patient who is having a neurological diagnostic test. So they may have impaired physical mobility, it could be at risk for injury, could have some acute confusion, may have some altered thought processes, again, which would kind of go along with the confusion. May have a self-care deficit for those that require that they remain on bed rest for a certain amount of time. Could have some pain related to the injection sites, altered tissue perfusion. Knowledge deficit could just come from not knowing about the disease or not knowing about the procedure. Altered nutrition, usually that's going to be probably less than requirements. Risk for aspiration, and then also they may be at risk for impaired skin integrity, again, just due to that possibly having to be on bed rest for a certain amount of time, that's after that procedure. So this part was short, but I couldn't fit it all in the first 30 minutes. So this will conclude the diagnostic neurological test.